Good morning. I'm Abhinav Sidana. I'm happy to be back here today, and I'll be speaking on combination of prostate ablation and systemic therapy in prostate cancer. Following are my disclosures. My talk has two objectives today. The first is to discuss the rationale and review the evidence for anti-tumor immune response generated by tumor ablation. And secondly, to discuss methods to potentiate this anti-tumor immune response to achieve meaningful clinical response in humans. To understand this concept, let's review the mechanism by which cryoablation destroys tumor. And I've chosen cryoablation here because that's an energy modality I used in my research. However, I'm certain other energy modalities will have similar tissue response. Cryoablation induces cell death by causing direct damage to the cell membranes. It freezes the cell membrane and disrupts those. And it also causes vascular compromise by causing thrombosis in the small blood vessels supplying prostate tissue. It releases tumor antigens in an inflammatory medium, which has a potential to stimulate anti-tumor immune response. As early as in 1960s, a urologist in Chicago, Ablan, discovered that the metastatic tumor burden in prostate cancer patients reduced after primary prostate cryoablation. And he named the phenomenon cryoimmune therapy, which was immune therapy using cryoablation of tumor. Over the last 4 decades, dozens of animal studies have demonstrated the existence of cryoimmune response using different tumor models. Freezing of tumor leads to destruction of cell membranes and coagulative necrosis of tissues, which releases tumor and cellular antigens in an inflammatory medium. These intracellular contents serve as danger signals to the body's immune response. The immune system recognizes them and responds by sending dendritic cells to that area. Dendritic cells are antigen-presenting cells. They go to the tumor ablated site, pick up antigens, and present them to helper T cells. These helper T cells then get activated. They further activate CD8 T cells, which are cytotoxic T cells, and lead to tumor cell death by several mechanisms. When I was at Hopkins, we conducted animal studies evaluating this response in the setting of established metastatic disease. We created a colon cancer model using CT26 cells in biopsy mice. We injected 1 million cells subcutaneously on flank to create a flank tumor and injected another 10,000 cells through the tail vein to establish metastatic disease. We divided these mice into 4 cohorts. Half of the mice also got intraperitoneal injection of cyclophosphamide. We used Cy as an immunomodulator here, as the previous studies have demonstrated. The low-dose cyclophosphamide reduces the proportion of regulatory T cells, which are inhibitory T cells. So by reducing the inhibitory T cells, it augments an anti-tumor immune response. We found in our studies that the mice who received cryoablation of the flank tumor plus low-dose cyclophosphamide lived longer than the mice in the other 3 arms. And the mice in the cryo plus Cy arm, 25% of them were actually cured of metastatic disease completely. We extracted CD4 positive lymphocytes from the spleen and draining lymph nodes from these mice and stimulated them with AH1, which is an immunodominant epitope on CT26 cells. The lymphocytes from the cryo plus Cy treated animals demonstrated increased expression of interferon gamma, proving that this immune response was specific to the CT26 cell line. The cryo plus Cy mice also had significantly decreased proportion of regulatory T cells, further demonstrating the efficacy of cryo plus Cy combination. Using this and other similar animal studies as our background, we initiated a trial of cryoimmunotherapy for the treatment of metastatic cancer. We kept the same regimen as we used in our mice studies. These patients had cryoablation of one easily accessible tumor focus along with low-dose cyclophosphamide. Most patients had urologic cancers and had already failed 1 or more line of therapies. While there was no clinically significant response in absolute tumor burden in these patients, the combination treatment decreased the rate of growth of metastatic tumor burden after cryoablation. IL-6, IL-10, TNF-alpha, and TRAIL levels showed a significant rise immediately post-cryotherapy. There was trend in the reduction of regulatory T cells, but no significant change in CD4 or CD8 count cells were found. This trial showed some signal, but that was not clinically significant. We learned that we need more persistent immune stimulation over a longer period of time and in patients with lower cancer burden to demonstrate a meaningful clinical response. And for that, we need potentiation of this immune response. While plethora of animal studies have demonstrated existence of this response, the response is never consistently immune stimulating and strong enough to control established metastatic disease. To capitalize on these, we need to intensify this immune response by adding immunomodulators such as cytokines, TLR agonists, or immune checkpoint inhibitors. Immune checkpoint inhibitors such as nivolumab and pembrolizumab probably are most promising because they're already widely used in clinical practice. However, would these work synergistically with ablation? This was studied by Dr. Allison's group in MD Anderson. They used two tumor model in mice. They gave the mice a flank tumor, treated mice, and then re-challenged the contralateral flank with the same cell line. They demonstrated that the mice treated with cryo, along with immune checkpoint inhibitor CTLA4, demonstrated significantly slower growth of secondary tumor. A proportion of mice in that arm completely rejected the second tumor. When they did immune fluorescence studies on secondary tumor, there was increased infiltration of CD4 and CD8 cells in the mice treated with cryo plus anti-CTLA4, again demonstrating the synergistic effect of the combination on anti-tumor immune response. We've been working with our collaborators in medical oncology and industry to develop a phase 2 study of ablation-induced immune response augmentation in humans. And we are hoping to enroll patients who have castrate-sensitive prostate cancer with minimal metastatic disease. And since with advent of prostate MRI, we can localize the tumor in the prostate. We'll ablate just the MR visible lesion to generate tumor antigens and combine standard of care therapy along with an anti-PD-1 agent to augment an anti-tumor immune response. Our primary objectives would be radiographic progression-free survival and safety and tolerability of this combination. To conclude, prostate ablation works synergistically with systemic therapy in controlling prostate cancer. We have a multi-institutional trial of focal ablation with ADT and novel hormone therapy in localized prostate cancer, currently being open at Hopkins and University of Cincinnati. We're hoping that by opening a trial with immunomodulators and prostate ablation, we can evaluate the role of combination management in advanced and metastatic prostate cancer. Thank you.